Good afternoon. I'm Dr. Robert Eisner, Hematology Oncology physician at the Northwestern Medicine Warrenville Cancer Center. Thanks for listening in today. Today we're going to talk about chronic lymphocytic leukemia. And so we'll start off with, I'll go through some question and answers, which I put together myself. I think it'll be informative for you. And then at the end, we'll take the rest of the time to answer any other questions that you have. So feel free to go ahead and put your questions into the chat box area. CLL, chronic lymphocytic leukemia, is one of the most common blood diseases that we see in the clinic. And it is a diagnosis which is often made when a person goes to their doctor for a routine blood count, for example. You might go for a regular CBC at an annual physical, and your physician might check a CBC, and your white blood cell count might be a little bit elevated. You might look at the rest of the blood count, and the lymphocytes are elevated in that same blood sample. Occasionally, somebody might be anemic or have a low platelet count, and then that would get your physician's attention, and often then we would be referred to a specialist like myself to investigate a little bit further. So there are definitely many things that could present in the same way, but we make a diagnosis of CLL by using a special machine called a flow cytometer, which is basically just a cell sorter. Really, it just takes the cells and it puts them through the special machine, and it divides them up based on what proteins are on the surface of those cells. And there's a particular, what we call immunophenotype, or a particular set of proteins on a CLL cell, which puts you in the bucket of CLL if that were to be the case. So that's how we make the diagnosis. Often when I see patients in the clinic, the next question they have is, well, if I have leukemia, then why don't I feel sick? Why do I feel so good if you're telling me I have leukemia? And so CLL does come in different flavors. The most common presentation, as I described, is someone that just comes to see their doctor and is found to have an elevated white blood cell count. But there are other patients that come in significantly anemic, significantly having a low platelet count. They might have enlarged lymph nodes, they might have an enlarged spleen, they might have an enlarged liver, and some patients might have a really, really high white count. Even some patients could have a white count that makes us worry that they could have acute leukemia, which is a wholly different situation. Anyway, so every case is different, but in general, many patients with CLL don't have symptoms. But if they were to have symptoms, they might have something like symptoms from the anemia. In other words, so anemia is when your hemoglobin is low. So patients may be pale, they may feel short of breath, they may feel weak. Sometimes they might have a headache or palpitations, feel their heart pounding in their chest. So these are symptoms that would be related to anemia. Sometimes if the platelets were low, a patient might have bleeding, or they might have bruising on their skin, or we might see these little dots called petechiae, which happen to usually occur on their skin, particularly the lower legs. And these could all be an indication of an advanced case of CLL. And then, as with a lot of other types of blood diseases that we see, patients might have fevers or chills or night sweats. They might have swollen lymph nodes. So a patient might, for example, complain of a lump under their arm or a lump in their neck. And then oftentimes there will be fatigue or weakness or weight loss can be associated with it. Now, when we see patients, we always examine them. We check their blood counts. We always want to know if the patient's liver or spleen is enlarged, because that can cause symptoms as well. If your spleen is really enlarged, you might have a loss of appetite, or you eat a meal and you get full too quickly. That would be an indication of a spleen being enlarged. But we examine patients, and we are usually able to detect that abnormality. So patients come in a variety of situations, the most common one being asymptomatic with just an elevated white blood cell count. So then we get a little deeper into the discussion, and then patients want to know what to expect. So then the question is, what is the natural history of CLL? So by definition, CLL is an indolent lymphoproliferative disorder. And what we mean by that is that it is a slow-growing disorder. Slow growing is a relative term, but in general, there are some cases that grow faster, some grow slower, but in general, it's an indolent condition. And over time, what tends to happen is the white count becomes more elevated. It can get higher and higher and higher. And so sometimes we'll see a white count start out, not too high, but over the years it might go up to, 20, 50, 30, 100, 200,000, 300,000. We usually are able to watch people pretty well until they get to really high levels. We'll talk more about treatment in a little bit. But as that white count tends to rise, the bone marrow sort of becomes filled in with these extra leukemia cells that don't belong there, and then you start to lose your ability to make to have blood production in a normal way. So patients might become more anemic, or their platelets could drop. These CLL cells tend to infiltrate the liver and spleen and make organ enlargement, and patients tend to get more symptoms. And so that is the natural history of CLL. But some patients can go for years, and some can go their whole life and never develop any symptoms associated with CLL, and some will evolve in a more rapid fashion and require treatment. So it can be somewhat heterogeneous, and there are ways that we can predict which patients might have a more progressive course, and we'll talk about that momentarily. So the next thing that patients often ask me is, are there any other diseases or illnesses associated with CLL? And of course the answer to that is yes. So sometimes patients are having CLL and they're just monitored without treatment. And then I caution patients, if they have a sudden increase in their anemia, if they have those symptoms which I described to you, or if their platelets drop and they're having bleeding, sometimes CLL can be associated with an overactive immune system, and you can actually get what we call immune thrombocytopenia or immune hemolytic anemia, where you're actually your immune system breaking down your own blood. So these are rare complications, but they're worth noting. The other thing that's worth talking about in patients with CLL is it can be associated with what we call a Richter's transformation, or a transformation to a diffuse or more aggressive large cell lymphoma. And when that happens, that's more of a high-risk situation that requires aggressive treatment. Fortunately, that happens infrequently, but it is a risk, and that changes the situation considerably. And then these days, we are frequently talking about immunodeficiency or in patients with CLL, and also many other of the blood diseases that we see. That's particularly important to talk about right now in this day and age because of the COVID-19 pandemic that's going on. So we know that patients with CLL have an immunocompromised immune system. Some patients, not all, but they may have a harder time handling different infections, particularly the COVID-19 infections. So for patients with CLL, they are considered high risk. So we do encourage patients to get the COVID-19 vaccine. And as of last week, we're encouraging patients to get the third booster shot, as recommended by the CDC. That's supposed to be given 28 days after the second vaccine for patients with CLL. Now, we've also noted that in patients with CLL, the vaccine may or may not be as protective as it is for some other patients who have a normal immune system. So there is concern that patients that have CLL, even though they've been vaccinated, need to continue to take precautions with distancing and masking and be a little bit extra cautious. So important. Now, there's also a higher risk of shingles infections in patients with CLL, so we do recommend patients get the shingles vaccines, flu shots as well, and we do often recommend, in some cases, we even prescribe medication to prevent reactivation of shingles. So there's many more conditions that can be associated with CLL. There may be a higher risk of skin cancers, and there's a short list of other things, but those are the highlights for you. So the next question that patients often ask me is, well, what are we going to do to get rid of this? Like, how are we going to treat it, right? You get diagnosed with something, we tell you it's a cancer of the lymphocytes of the immune system, and we need to know how we're going to get rid of it. So as you recall, I mentioned that CLL is an indolent or slow-growing disease. And so in many cases, the best treatment is no treatment or observation, because the treatments that we give all have side effects. They all have risks involved in these treatments. And back from the early days when physicians were studying this, they found that there's actually, in many cases, for an asymptomatic patient with normal blood counts and no fever, chills, night sweats, weight loss, or bulky lymphadenopathy, lymph node enlargement, or their spleen's not enlarged and they don't have any symptoms, that there's actually no benefit to treating early versus late. And this is really hard for someone to wrap their brain around, because people have been dealing with, learning about other kinds of cancers like colon cancer, where you should get a colonoscopy because you can, cure it through surgery, and breast cancer, screening mammograms, you can cure it early. Early treatment is lower stage, higher cure rates, right? But with CLL, it's a different paradigm. So many patients without any indications for treatment are observed. But there are some patients who require treatment. And again, those are patients with big lymph nodes that are symptomatically bothering them, enlarged livers or spleens, very, very high white blood cell count, or with associated low blood counts like the anemia and the low platelet count. So those patients are requiring treatment, but a majority of patients in a hematologist practice are on follow-up without treatment, and they get close monitoring. So, excuse us just 1 second. Sorry about that. So when we meet a patient that has CLL, there are some things that we can do to risk stratify patients in terms of their risk of going on to develop symptomatic CLL and the need for treatment. And so oftentimes physicians will talk about doing what's called a prognostic panel with the patients. And a prognostic panel includes a number of different things like the mutational status of the IGVH gene, something called cytogenetics, where we'll look at the genes of the CLL cells with standard cytogenetics, or we might use a technique called FISH. We might use something called a ZAP70 score. We can do things like the CD38 status, and these sort of are biological tests that sort of look into see what the biological behavior may be over time, because some of these diseases will be more indolent and some may be less indolent. Again, it's a continuum of an indolent disease, but some will grow faster than others. So putting it all together, we're able to identify a risk profile, and we might be able to predict what may happen in the coming years. And in some cases, I'll tell patients that you have a high-risk disease, we should monitor you a little bit more closely. And other patients that have the lowest risk, we might say, well, we probably just need to see you once a year, so that there is quite a bit of variability. So how can observation be the best treatment for patients? Well, because the patients who have a low risk of progressing and have a low risk of developing symptoms might actually be harmed with the treatment in the short term, whereas not that treatment will never be necessary, but treating patients at the right time is the art of the medicine here. So waiting not too long, but waiting till just the right time to intervene so that we can treat CLL. So CLL is extremely treatable. Okay, in the old days we used to use chemotherapies, like good old-fashioned cytotoxic chemotherapies, which had all the side effects which are associated with chemotherapy: hair loss, nausea, vomiting, infection risk, low blood counts, fatigue, all the terrible chemotherapy things that we have used in the past. And in the modern era, we hardly give chemotherapy at all anymore, although it's still an option, and it can still be highly effective. But we've really moved into this era of targeted therapies where we're using medications that are called BTK inhibitors, or medications like BCL2 inhibitors in combination with other targeted therapies like the CD20 antibody type drugs. So these are highly efficacious medications. They have a much more favorable side effect profile, but there are many considerations when we're considering choosing therapy for a CLL patient. The last thing I want to say before we transition to the question and answer session is there's a lot of investigation going on in clinical trials trying to figure out what is the best cocktail or the best combination of treatments for patients with CLL. So we always encourage participation in clinical trials when available. There across the country, there are clinical trials in older patients and younger patients individually. And there are also clinical trials going on testing earlier treatment for patients that are high risk as to compare to observation in that high risk patient population. So it's an exciting time to be a physician treating CLL, and there's a lot coming down the pipe in the future, and the disease is something that's definitely gratifying to treat, and patients tend to do well, but there's still much of an unmet need. So I'll be happy to stop and take any questions if we have any at this time.
We do. We've got two that have come in so far, and Tina is asking, do patients on watch and wait with minimal symptoms qualify for early booster vaccine, or do you need to be on active treatment?
Yeah, that's a great question, and I think I'll tell you my own opinion is yes, you should get the booster shot. That patients with CLL who have, whether they're on treatment or not, should have the booster shot. I'd have to go back a little bit closer and look at the recommendations from the FDA and CDC, but I'm nearly certain that most hematologists would concur that a patient with CLL should get the booster shot at 28 days after the second shot, whether they've had chemotherapy or immunotherapy or not.
Another question, from the EVOLVE study, are you seeing a benefit to early treatment, or is it too early in the trial to tell?
Yeah, we don't have any public knowledge or feedback yet on that trial results. I think it's not been open for very long, and we just don't have any data on that.
Okay, speaking of trials, is there, I know that you mentioned that there are trials. If someone wanted to find a trial, what's the best way? Is it ask your doctor? Is there a website people should go to?
Well, I mean, communicating with your physician is always the best avenue, I think. But for anybody that has any kind of question about clinical trials in cancer, the best website out there is clinicaltrials.gov. And it's a fantastic database. All clinical trials have been registered with the NCI or will show up in that database. And you can search on any kind of cancer, any stage, by phase. There's so many different filter fields you can go through. And it's a great opportunity to search all kinds of cancer trials that are open across the world.
Another question. If for a younger CLL patient, is it possible to have children naturally? Is it something that is recommended, not recommended, or is it on a case-by-case basis?
Yeah, I mean, again, it really depends. So CLL in children and in young adults is actually very uncommon. So it does tend to be a disease of older people, but it could happen. And the prognosis is usually good. So there would be really no ethical or other issue with having children. And as far as fertility preservation, that would be considered if someone was going to be on treatment. But if a person was going to be monitored, then nothing specific would need to occur in terms of fertility preservation. But if treatment was an issue, then of course we have experts in the community who deal with fertility issues related to oncology patients and related to their treatment in specific.
Got it.
So I can tell you, I don't believe in my career I've ever seen a patient young enough, with those issues that actually had CLL. It does tend to be a disease of older people. I'm sure there's some out there, but it is a disease of older people.
Can CLL metastasize to other organs without showing in the blood work?
Mm-hmm. Yeah. So normally, CLL is already a systemic process when it's diagnosed because it diffusely involves the bone marrow. So if you were to sample the bone marrow from any part of your body, you would see CLL cells inside the bone marrow. So it's already disseminated by definition when you diagnose CLL. So we really wouldn't call it metastasizing. It already has spread throughout the body by the time we diagnose it. That's just how it behaves. That's what it does. It doesn't tend to cause tumors of your liver, tumors of your lungs. It can do those things, but it tends to involve the lymph nodes as well as the spleen. Tend to be the most common sites of involvement from organ involvement. So, and those things are exceedingly common. So we are not surprised at all when we see a patient with an enlarged lymph node and they get a biopsy and it shows CLL in the lymph node, which we call SLL, and then we check their blood and they have CLL in their blood. So this happens routinely. We almost expect to see lymph node enlargement when we see somebody with CLL. But again, doesn't tend to involve the organs like the lungs or the any solid organs. Although it can. I have patients with we have patients with involvement of all kinds of organs, but those are the not common scenarios. Those are exceptions rather than the rule.
Two more questions. There are a few BTK inhibitors available. Mm-hmm. Do you prescribe one over the other, or does it depend on type of leukemia or risk factors?
That's a great question. It's not so much based on the type of leukemia, but it more so is based on the type of the patient. So the first BTK inhibitor that was put out on the market was this Ibrutinib drug. And it's a great drug, but it has a little bit less specificity for the BTK enzyme pathway. And so the newer ones that have been come out on the market, like acalabrutinib or zanubrutinib, they are a little bit more specific to that BTK enzyme cascade. And so people talk about off-target side effects. So the Ibrutinib drug may have actually a few more side effects compared to the newer generations, the acal or the zanubrutinib drug. So particularly we worry about side effects of cardiac toxicity or atrial fibrillation being one of the more common side effects associated with Ibrutinib, but much less common with acalabrutinib or zanubrutinib. And the other thing that is often worried about is the bleeding risk, because these BTK inhibitors can increase the risk of bleeding, felt to be more so with the Ibrutinib rather than the other two. And in general, there's felt to be fewer side effects and a little bit of a better safety profile associated with the newer generation drugs. So that's kind of how we make these decisions. If you have a patient that already has pre-existing cardiac disease, then we tend to use acalabrutinib, for example. Part of it's driven by insurance as well. You know, there's different contracts and certain things are approved, and so that's also a consideration. And cost, because the curse of these drugs is that they're so effective, but they are so expensive. And with a drug like a BTK inhibitor, you have to be on that drug pretty much indefinitely. You stay on the medicine to suppress CLL, which is a problem if you're having side effects, because even low-grade side effects for a long period of time can become very, obnoxious or life-altering. And the cost of it, if you imagine being on a drug for many, many years, even though your disease is in remission, it can be extremely expensive, which can be a really burden, especially for retired people with high copays and limited income.
Are there any instances of CLL being cured?
Well, that's a great question. We don't really like to talk about cure in CLL because we really don't consider it a curable disease. But with that said, there are patients from the old studies that were done in the past decade where a particular subtype of patients, those with what we call the mutated IGVH gene, who went on a particular type of regimen called FCR, which is pretty toxic chemotherapy. But there's a subset of those patients in some of those early trials that really just never relapsed, and we do think that some of them might be cured. And so where the new trials have come in, or some of these newer drugs, we have a drug called these BTK inhibitors, which we've already talked about, but there's another drug called venetoclax, which is what we call BCL2 inhibitor. So there's a difference between, I don't want to get too technical here, but if we have time, I can just shed light on a few things. So the BTK inhibitors are good at suppressing CLL and controlling it, whereas venetoclax is good at causing complete remissions, or in other words, eradicating the last CLL cell, causing a very, very, very deep remission. So there's a lot of the trials going on now are saying, well, let's take the drug that's good at controlling it and combine it with the drug that's good at deep remissions and curing that last one. Combine them and see do we cure patients, right? So we're trying new combinations to see if we can actually functionally, cure somebody from a CLL. So that remains to be seen if those combinations are going to be better than each of those drugs sequentially. One, and then then it progresses, then the other. So it's going to take years to figure out if these newer approaches are effective. But taking combinations of drugs with non-overlapping side effect profiles is kind of how we develop new treatments for cancer, and that's what we're doing.
Last question, I believe, is, it's a COVID question, and I'm not sure if you'll know the answer. How do I schedule an early booster vaccine? Is this something I coordinate with my physician?
Yeah, so it depends who your physician is and what health system they're associated with and which day of the week it is, because that's a rapidly evolving situation. So at the current time, I'm telling patients just to go ahead and try to schedule a Walgreens or CVS or Mariano's or any pharmacy of their choice. There's no shortage of these vaccines right now, so it should be no problem to get the shot. And all these companies are following the recommendations of the CDC. So if your doctor works for a large health system that has a vaccination program, by all means, that might be great, but there's no reason why you can't walk down to the corner drugstore and get it done today.
Awesome, that is it. Thank you so much.
Thank you very much. I appreciate you listening today.